We've heard some quite interesting data on local therapy in breast cancer, which is important to the multidisciplinary team as a whole. So we have a multidisciplinary team to discuss it. We have Catherine Harper-Wynn, Susie Cleater, Julie Doughty, and David Dodwell.
I'll present the 10-year follow-up results of the NSABP 32, a randomised phase 3 study looking at the comparison of sentinel node resection to conventional axillary dissection in clinically node-negative breast cancer patients. So this randomised 5,611 patients with clinically node-negative invasive breast cancer. And in group 1, which was a sentinel node resection and axillary dissection group, there was 1,975 patients. And in group 2, the sentinel node resection alone group, there was 2,011 patients. Of these, 3,986 patients were sentinel node negative with follow-up information on these patients. Median time on study was 9.4 years, and from previous presentations we know that the false negative rate in this study was 9.8%. At 10 years, there continues to be no significant difference in overall survival or disease-free survival between both of these groups. This is using the Kaplan-Meier 10-year estimates, which show overall survival 87.8 for the sentinel node resection group alone, and 88.9 for the sentinel node resection and axillary dissection group, with a hazard of 1.11, and the p-values you can see insignificant here. The disease-free survival, 76.9 for both groups, hazard 1.01, and the p again 0.92, non-significant. This group actually examined occult nodal metastases, having done H&E first of all to make their treatment decisions, and then IHC to fully evaluate the occult nodal disease. And they originally detected 616 patients, i.e. 15.8% with sentinel node negative, which had mainly micrometastatic disease and ITCs. But comparing these groups, so occult node positive versus occult node negative, there was disease-free adjusted, showed a hazard ratio of 1.24, which was significant, with an absolute difference of 4.1%, but no difference in the overall survival, with a hazard of 1.25 and the p-value at 0.08, with an absolute difference of 2.8%. The cumulative incidence of local regional events was low and is not significant. So at 10 years, there continues to be no significant difference in overall survival and disease-free survival between sentinel node resection and sentinel resection and axillary dissection in patients with node-negative sentinel lymph nodes. Statistically different, a significant small reduction in the risk of disease-free survival for patients with occult sentinel lymph nodes makes no apparent difference, and there's no overall survival difference. So therefore, there's no justification for undertaking IHC on sentinel node resection specimens to pick up occult metastases in this group.
Hi, David. So I think that was quite an interesting session this morning. 3 interesting papers presented. The first is the long-term 10-year follow-up of the NSAPB 32 trial. So that was the kind of American equivalent to our Almanac study. I think one of the interesting things about this is it's a very robust study where they managed to get really good follow-up on kind of 99% of the patients. And I think it just reconfirms how safe sentinel node biopsy is as a procedure. I think everybody has accepted that already, really, but this was just a little bit of icing on the cake to show that a 10-year follow-up, there was absolutely no difference in either survival, overall, or disease-free in the patients who had sentinel node alone or those who went on to axillary dissection.
Yeah, that's right. I mean, it's always good when long-term follow-up confirms the messages that we've already seen from earlier presentations of this trial, and as you say, it supports the Almanac results, and it's now very clearly a standard of care and saving many women in axillary node dissection that I remember that used to be routinely practiced. I think there's a couple of interesting little asides that come along from this, really. One is that important relationship between the the false negative rate of sentinel node biopsy, which is still about 10%.
Yeah.
You know, that's a significant false negative rate, and yet the ultimate risk of axillary recurrence, isolated axillary recurrence, is really low, about 0.3%. So that's a 30-fold difference between there probably being microscopic disease in the axilla to that disease causing that particular patient a recurrence. And obviously we can speculate on the reasons for that, which could include treatment with systemic therapy or treatment with the breast tangents that do, as we know, sometimes encroach on the lower axilla. I think the other thing that's of interest to me is this also shows a really low rate of within breast recurrence. We're looking at, 3% at 10 years now. That is really low, and that's important. I mean, this is 10-year follow-up, so these are patients treated some time ago, and yet they're achieving fabulous results. And we have to take that when we think about designing other trials in terms of breast conservation, because improving on that is really going to be very hard. So very positive, very useful study, simple message. I guess the business about what we need to do about occult disease in the axilla is of some interest. I don't know if you wanted to come back about that.
Well, I think this study initially, when they presented the 8-year study, one of the kind of this study, as well as just looking at recurrence rates, it also took a group of patients which had IHC and further sectioning done on the lymph nodes. And when they presented the data at 8 years, which was published, the last data they presented, there was a very small but significant increase in overall survival in patients with occult lymph node metastasis found on either further sectioning or immunohistochemistry. But with this longer follow-up, it has shown that this difference is now not significant. And I think that's really in keeping with what other studies have shown. Yeah. That if you do IHC or you do further sectioning and you pick up this occult disease, it isn't significant. No. I think the point though about the low recurrence rates, although there is this 10-year follow-up, I think when these patients were recruited, these patients would have all had ER done. They wouldn't have all had HER2 initially, but they would later on. So I think they've had, appropriate, good adjuvant therapy. Yeah. And I think that's probably one of the main reasons why recurrence rates are so slow.
And they are intrinsically a low-risk group. I mean,
yeah.
Overall survival was, 90%, 85, 90% at 10 years. This is low-risk breast cancer.
I mean, it would be great to say it was because the surgery had been so fabulous, but I think we can't take all the benefit for that.
And my American clinical oncology colleagues are equally skilled, I'm sure.
Absolutely.
Okay, so I'm going to present a late-breaking abstract, which was a randomized study by the EORTC, the AMARAS trial, which randomly allocated patients to either axillary radiotherapy or axillary node dissection after positive sentinel lymph node. So this was patients with clinical stage T1 to T2 and clinically node negative axillas. The patients were actually randomized as to whether they would receive radiotherapy or surgery prior to undergoing their surgery and establishing the lymph node status. Of those patients who were found to be node positive, only 60% of those patients actually had macro metastases within the axilla, with the remainder being micrometastases or isolated tumor cells. So this was a study with a median follow-up of 6.1 years. The primary endpoint was actually 5-year axillary recurrence, and it was powered for non-inferiority, with secondary endpoints of overall survival, disease-free survival, quality of life, shoulder movement, and lymphedema at 1 and at 5 years. So this table here shows the results for the axillary node dissection versus axillary radiotherapy. So the arms are well balanced. with approximately 700 patients in each arm, and it can be seen that the overall survival and the disease-free survival, as well as the primary endpoint, were equivalent in each arm. The risk of lymphedema was found to be significantly increased in those that had undergone surgery, essentially doubled at 1 year, 40% versus 22%, and at 5 years, 28% versus 14%. There was a non-significant trend towards impairment in shoulder movement in the surgical arm, but this is actually something that dissipated with time in any case. It was only seen at 1 year. So in summary, axillary lymph node dissection and axillary radiotherapy after a positive sentinel lymph node biopsy both provide excellent regional control and are in fact comparable, with a significantly increased risk of both short-term and long-term lymphedema in the surgical compared to radiotherapy arm. Other trial data has actually suggested that patients with micrometastatic disease, isolated tumour cells, or low-volume macrometastatic disease, 1 to 2 nodes, may actually not need any further local treatment to the axilla. This was shown in the IBCSG and Z0011 studies. So in fact, we have to consider that a significant proportion of the patients within this trial were actually probably over-treated.
So the second study, I think, is the one that we'd all been waiting for, the results of the AMARIS study, the study which took patients who were sentinel lymph node positive and randomised them to either a clearance or to axillary radiotherapy. And this is, I think, what we've all kind of been waiting for. So what were your thoughts on this?
I think this is a really good study, a difficult study to do. And I think the ORTC group really need to be congratulated. They're ahead of their time when this was set up. And the point is that this is proper axillary radiotherapy, third field radiotherapy. We're not talking about the breast tangents encroaching on the axilla. This is proper, thorough axillary radiotherapy treatment, which can only be achieved by a third field of treatment. So, I mean, the design of the study meant that there was a whole lot of patients, I think about 4,000, but the way it was done, they needed that number of patients because the randomization was done before surgical treatment. Yeah. So obviously the patients that were node negative then dropped out of the study, and we're left with a node positive group who, as you say, were randomized between surgical treatment to the axilla with an axillary node dissection with good quality control, and also good quality control in relation to the recommendations for axillary radiotherapy treatment. And this is another attribute to the RT group within the ORTC. I think that it's probably important to reflect on some of the selection issues here. About 60% of these patients, I mean, obviously they were clinically node negative, but 60% had an axillary ultrasound. So I think that would be a much lower percentage than we would expect to treat in the UK in terms of selecting out the node positive group. And then ultimately, for those patients that were node positive, about 60% had macrometastases within the axilla, within the lymph glands within the axilla. About 30% had micrometastases, and there's a small group who had infiltrating tumour cells. And they were ultimately excluded later on because it was recognised that ITCs alone have no real significance for local or distant failure. And I think that results are, again, reinforce some of the issues about axillary recurrence, which is really very low with either treatment. And although numerically slightly higher in the radiotherapy group, really very low and equivalent statistically between surgery and radiotherapy treatment. Now, obviously, one of the things with this study is that, and with all these axillary studies, is that ultimately you're still treating 60 or 70% of patients who actually don't need treatment, because in the axillary dissection group, about that percentage, 60, 70% of patients ultimately were node negative. So it's an important study, but it probably also means that it's important to reflect on actually whether we need to ask that question about who actually needs treatment of the axilla, whether it's surgical or radiotherapeutic. And obviously the significant message from this really is that although there was equivalence in efficacy terms, there was a clear difference in terms of toxicity, with those patients having an axillary node clearance really having high rates of lymphedema. Now this is always a hard assessment, and to compare this to contemporary practice is difficult, but the risks of lymphedema were really quite high, I think, in the axillary node dissection group, and much higher than in those patients who had radiotherapy treatment. I don't know how you would expect these risks of lymphedema to reflect modern practice in your unit or in other units in the UK.
I mean, I felt that the lymphedema rates reported here were very, very high. So, you know, clinical lymphedema is a very, very subjective thing. He didn't obviously have time to go into whether there were arm measurements, whether it was just comparing the two arms. I think what he then reported was actually lymphedema that needed treated. Yeah. And again, in the patients who had axillary node clearance, that was almost 25% at 1 year. And certainly that would mean in your clinic that every fourth patient was having a sleeve fitted or massage, and certainly that seems very, very high. I mean, the other concern that I had about this was, I think the only study that's looked at similar morbidity is the Edinburgh study, where they did a sample and then patients either had radiotherapy or clearance. And initially, at shorter follow-up of up to 5 years, you did get a lot more problems with clearance. But as time went on, and when I think the last presented at 15 years, there was significant more stiffness and problem with the shoulder in the patients who had radiotherapy. So, I mean, I think this is the final analysis, is how we reported it. So I think we will probably never get to know that. But I think the commentary on this was very interesting, because in a way, to me, it's almost like a historical study, and that I think today we shouldn't be asking who should have a clearance, who should have radiotherapy. We should be trying to pick out of this group, as you said, the 60% of people who don't actually need any axillary treatment. Because even the patients who had radiotherapy at 1 year, 22% had lymphedema. So there's still, 1 in 5 are still having morbidity from radiotherapy.
You're right. I think that is the challenge, although it's a controversial and a difficult way forward. And I would agree with your comments about shoulder function. I think the Edinburgh study also did show worse shoulder function, and there was numerically worse shoulder function in this study, although it didn't quite hit. It wasn't statistically significant. But I mean, I counsel patients on equivalent efficacy but differential morbidity, using those facts really. And I think axillary radiotherapy is reasonable in some circumstances. I think it all gets down to patient selection. But a very important further study to add to the growing data that we have about the axilla. But the thing is about the axilla, as we both know, the more information there is, doesn't seem to take away the controversy.
But I think all the information is pointing in one direction. And I think, if you look at Z11, that was presented here 3 years ago. And, there's still units in the UK that are clearing patients who have micrometastases. Yeah. So, I think, sure, we should be cautious, but I think, as we can see from this study, these procedures, regardless of whether it's clearance or radiotherapy, are not without harm to these patients.
No, quite right.
I'm going to present now a retrospective data review looking at the effect of surgery type on survival and recurrence in young women with breast cancer. This is essentially mastectomy versus breast-conserving surgery. So on the Ontario Cancer Registry, a total of 1,381 patients under the age of 35 were identified. And these are patients that have been diagnosed between 1994 and 2003 with a median age of 33. And of these, 393 had breast-conserving surgery and 588 underwent mastectomy. The majority of the breast-conserving patients naturally underwent radiotherapy, that's nearly 90%, and approximately half of the mastectomy patients underwent radiotherapy. So there was a median follow-up of 11 years. Overall, over this time, 38% of the patients have sustained a recurrence and 31% have died. Tumour and patient characteristics were evaluated, including tumour size, margin status, node status, grade, lymphovascular invasion, immunophenotype, and treatment. So, not surprisingly, the patients who had undergone mastectomy did worse because they were obviously a group with poorer prognosis. But when correction had been made for known covariants such as grade and stage, there was actually no difference in overall survival between those that had undergone mastectomy and breast-conserving surgery. The predictors of recurrence overall were, as you would expect, tumour size, nodal status, whether or not the patient had undergone neoadjuvant chemotherapy, which is of course a reflection of tumour stage, and also there was a very marked effect of lack of radiation. And the predictors of death were similar in each group. So what this study tells us is that in young women in whom there's often a tendency to want to undertake mastectomy, it is actually safe to undertake breast-conserving surgery. There were some important data points missing, and in particular there were no clinical genetics data. So, for example, we would expect this population to be enriched for patients with Li-Fraumeni mutations. This is a group of patients in whom you would want to avoid breast-conserving surgery and associated radiotherapy, but unfortunately that data was not present. But overall, very reassuring results.
Well, the last of these studies then, Julie, is this retrospective review from Canadian colleagues who looked at around 1,500 patients with early breast cancer treated over a 10-year period. I think they've got about 10-year follow-up from this cohort who are under 35. And I think this is an important issue because we are all, I guess, more nervous about breast conservation in younger patients, and it's perhaps a more difficult area. It seems a paradox to me that it's obviously younger patients where the desire for breast conservation, breast preservation is higher, but we have perhaps more anxieties about younger patients. Possibly, I'm interested in your comments, but from my perspective, possibly for two reasons. One is the increased association with family risk. And the other one is simply the widely known and well-confirmed data that suggest, irrespective of genetic risk or family risk, that younger age is probably the most powerful driver for ipsilateral breast recurrence for invasive disease. So that's, of course, creates some anxiety in MDTs about safe breast conservation in younger patients. And this was a large study and I think well conducted, but I guess I'm concerned that there were quite a lot of exclusions. Almost half the patients were excluded because they couldn't find the data, and so you've got to worry about whether that has introduced some degree of bias. And so obviously it has significant limitations in that respect, and the fact that it is a retrospective study, although a large one and one with good follow-up. And really the message from me and the main point that I took from this was that in those patients who are under 35 who did have breast conservation, that the 10-year risk of ipsilateral breast recurrence was 12%. And I think that's reasonable, particularly given the likely use or less of use of systemic therapy in this patient group, because this is an older cohort. So it kind of underlines that selecting patients who are under 35, young women for breast conservation remains reasonable, providing those patients are appropriately selected.
Yeah, I mean, I think the first thing about this is it was started and they looked at patients from 94 to 2003. So some of those wouldn't have even been ER tested, never mind HER2 tested. There was a couple of things about the breast conservation. Quite a high percent had positive margins, so margins less than 0, and they had no further treatment. And not all the breast conservation patients got radiotherapy. There was 15%. So for me, that's not appropriate conservation surgery. So, and I think they certainly wouldn't have had what we would call optimum adjuvant chemotherapy. I think there's always a kind of, knee-jerk reaction when you get a young person and gene test them and should they have a mastectomy. But I think as this study showed, and we know from other studies that these patients had quite often bigger tumours, more grade 3 tumours, more ER-negative tumours. So those patients are often at higher risk of relapse, and therefore, to think, well, should someone have a bilateral mastectomy and bilateral reconstruction? I think, often the issue is actually, are they going to survive the kind of cancer they've got? So, I think a recurrence rate of that degree at 10 years would clearly be unacceptable these days, but I think in the time period it was probably quite a reasonable recurrence rate. I mean, I don't think this, for me, added much more because there were severe limitations of the study. And I think, it's interesting, but I don't think you can definitely say, that breast conservation surgery is better or safe from this study that they presented.